Hello, my name is Andrea and I am the pharmacist intern today and I will be presenting my patient case. Patient's name is Daniel Chen. He's a 65-year-old male. His date of birth is 12/28/1960. His actual body weight was 81 kilograms and then his height is 5 feet and 4 inches. He has a medication allergy to codeine, which causes nausea and vomiting, and he's presenting today with a chief complaint of his abdomen hurting. His history of present illness is that the patient presented to the emergency department here in the general hospital with 2 days of having fever and abdominal pain. He did deny headaches, vision changes, neck pain or stiffness, ear pain, nasal drainage, sore throat, trouble swallowing, cough, shortness of breath, chest pain, palpitations, pain of the extremities, and rashes. His past medical history includes NASH cirrhosis with ascites, encephalopathy, a previous spontaneous bacterial peritonitis episode, diabetes, obesity, and CKD. He currently does not get any hemodialysis. His current social history, he does confirm some alcohol use, a couple of beers daily. And then his review of symptoms, like said in the history of present illness, he did everything was normal, and then he did deny everything that was said in the history HPI. For his physical exam, he did present slightly drowsy and confused, and then his abdomen was distended and tender to palpitation. His vitals are all within normal limits except the temperature readings. On 4/6/2026, he read of a fever of 100.9, and then today 4/7, he read a fever of 100.7. His home medications include furosemide, spironolactone, lactulose, insulin glargine, insulin lispro, and ciprofloxacin. And then his inpatient antimicrobials that he was started on or other printed medications was ceftriaxone 2 grams over 4.2 milliliters. The dose is 2 grams IV every 24 hours. He did start all of these medications yesterday, 4/6/2026. He was also started on albumin 25%, 120 grams IV continuous, and then he was also started on insulin regular 100 units per 100 mLs. Dosing between 0 to 16 units, sub-Q as needed every 6 hours. For his pertinent labs, he did have elevated white blood cell counts both days, ranging between 13 to 14.3. He also had serum creatinine elevated both days, ranging between 2.8 to 3.0. He also had a B1 elevated between both days, ranging from 24 to 23. He had a total bilirubin also elevated both days, ranging between 4.5 and 4.9. He had elevated LFTs both days. He also had an elevated INR of 1.3. And then he had elevated segmented neutrophils ranging from 75 to 89. And then his albumin has been low both days, ranging between 3.2 to 3.3. For diagnostic/test, this patient did get multiple cultures and susceptibilities, but the most pertinent one was a culture from the acidic fluid culture that was reported on 4/7 today. The gram stain did show 2 gram-positive coccyte pairs and chains, and then his final culture showed vancomycin-resistant E. faecium. They also did a susceptibility of the medications and the MICs. The patient was susceptible to daptomycin and linezolid and was resistant to ampicillin, nitrofurantoin, and vancomycin. For the labs, he did have a peritoneal fluid analysis that showed body fluid type of ascites. A1 color was yellow, A1 clarity was cloudy. The fluid CD RBC was 21,119. Fluid nucleated cells was 959, which is like white blood cells. Fluid segs were 67%, fluid limbs were 12%, and then the mono/macrophage 21%. He did have also 2 microbiology cultures done, one on his right arm, one on his left arm. They were both obtained and reported on 4/7, 2026, and both arms showed no growth. And then his acidic fluid culture is the one that showed growth on 4/7. For this patient, their primary problem is a recurrent spontaneous bacterial peritonitis episode. This is priority number 1. Some of the key evidence that shows that he's having this episode is that his abdomen hurts, his history of present illness showing fever and pain for the last 2 days. His past medical history are definitely risk factors such as the NASH cirrhosis with ascites and then the previous spontaneous bacterial peritonitis. His temperature readings of fevers ranging between 100.7 to 100.9 between both days. His physical exam with the distended tender to palpitation abdomen reading. And then his culture and susceptibilities to the acidic fluid culture showing the positive vancomycin resistant E facium. He also has other notable risk factors such as the daily couple of beers alcohol consumption. And then he has a PMN count of about 643 cells, this is a diagnostic tool to diagnose spontaneous bacterial peritonitis, and the threshold is less than 250. His pertinent labs that are key evidence are the white blood cells ranging from 13 to 14.3, his INR of 1.3, his total bilirubin ranging between 4.5 to 4.9, his albumin being consistently low between 3.2 to 3.3, serum creatinine, like said before, 2.8 and 3.0, BUN ranging from 23 to 24, his electrolytes being low, especially his sodium, ranging between 133 to 134, and then his acidic fluid analysis, and then having elevated LFTs all around. So the therapeutic goals for this primary problem is the resolution of the spontaneous bacterial peritonitis infection, relieve of the signs and symptoms of the infection, prevention of complications / long-term sequelae, prevent recurrence, minimize adverse drug effects and collateral damage, provide cost-effective therapy, and then achieve a resolution of infection without major organ system complications. So recommendations for therapy, for pharmacological therapy, I would recommend discontinuing ceftriaxone 2 grams over 4.2 mLs, the dose being 2 grams IV every 24 hours, and then also discontinuing the ciprofloxacin 750 milligrams by mouth once weekly. I would recommend initiating daptomycin 700 milligrams, this being dosed with weight-based dosing of 8 milligrams over kilograms, IV infusion over 30 minutes every 48 hours for 5 to 7 days. Every 48 hours due to their estimated creatinine clearance of being less than 30 mLs per minute. And it would be continued for 5 to 7 days as long as fever and pain have resolved. Day 1 is the first day of the patient receiving their first dose of daptomycin. So if they started taking daptomycin today 4/7, then today would be day 1. I would also like to initiate a different prophylaxis, ciprofloxacin 500 milligrams by mouth once daily after the completion of the daptomycin therapy. This would be more optimized prophylaxis just because this patient was already on prophylactic therapy and he still had a breakthrough episode. So I wanted to optimize the prophylaxis as well, so for future prevention. For non-pharmacological recommendations, I would recommend patient counseling on alcohol cessation or decrease, due to this increasing the risk of future spontaneous bacterial peritonitis episodes. And then continue the fluid therapy of giving another 1 gram over kilogram of albumin tomorrow, 4/8/2026, which would be day 3 since he started the albumin. And it would be albumin 25% and normal saline, 81 grams IV continuous infusion. And then for efficacy monitoring, we want to monitor for the resolution of the infection, the resolution of the symptoms, specifically the pain and the fever. Just because we would be discontinuing therapy as long as it's been resolved within the 5 to 7 days with the daptomycin. Resolution of the distended abdomen, resolution of the labs such as the white blood cells, the PMN reduction, serum creatinine, BUN, LFTs, INR, and albumin. And then to really monitor for the resolution of the infection, we want to do a repeat paracentesis at 48 hours of treatment. So if today's day 1, 2 days from now. And then to confirm that the infection is responding to treatment. And then monitoring for safety for dactylomycin, we want to monitor for C. diff infection, eosinophilic pneumonia, hypersensitivity reactions, myopathy, and rhabdomyolysis. So we want to monitor weekly CPK levels. And then we also want to monitor for peripheral neuropathy. For ciprofloxacin, we do want to monitor for, this is when the patient does complete their current daptomycin therapy and when they're going to be discharged or they complete their daptomycin therapy and they start their ciprofloxacin prophylaxis. We would need to monitor for nausea, vomiting, and diarrhea, allergic reactions, serum creatinine, urine output, C. difficile infection, CNS effects such as headaches, dizziness, confusion, malaise, and insomnia, QTc prolongation, blood glucose tendinitis, photosensitivity, and elevated LFTs. Thank you and have a nice day.